Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. All right, welcome back to the Equine Vet Connect podcast. I'm Dan Carter. We're here with Dr. Caroline Brown. We are in the old studio at Countryside Equine Hospital. So we're in the studio.
And it is the studio.
The treatment room 1. If y'all ever come in to see us, you'll probably recognize it. It's kind of fun when people come in. They're like, "This is where you film the podcast." I was like,
yes, it is.
Yes, it is. Why? 'Cause
multi-purpose room.
we don't actually have a studio.
No, that didn't go into the building plan.
No, when we built, I wasn't really thinking like, oh, we'll have a podcast one day. We should build a studio.
Maybe the next building.
Maybe.
Yeah.
Maybe.
Whole dedicated studio room.
And I'm a little nervous to move. That one time we tried to move in the location where we did this, and it went terrible.
It went south so fast. Like everything that could have gone wrong went wrong.
I mean, we even lost the video.
Yeah, we did.
It was a poorly done podcast. Like, we need to redo that.
Even the technology was like, no, you're not doing this. So never again.
Yes. So we learned it. Lesson learned. Lesson learned. So, speaking of lessons, the letter of the day today will be L, lessons, and we're going to talk about lumpology.
Lumpology. This is a passion of mine. I love talking about this.
It's pretty cool. Lumps and bumps.
Lumps and bumps.
When a lump is not just a lump.
Because there's a lot of different types. They're not all the same. They're not always related to each other. Sometimes just because you have one lump here doesn't mean it's the same as the lump over here. And sometimes we can ignore them, and sometimes we need to take some action.
Yes.
And we're going to talk about that today.
And I think when we talk about lumpology, I think this is one of those times more is definitely better than less.
Yes, absolutely.
Like, I would rather go overboard on a lump than, I guess, underboard.
Underboard, is that a word?
I don't know.
Look it up.
Yes.
So I would tell if it's a word or not.
If it's a word, let us know. If not, sorry. But I've heard this generation, they make up words every day.
Oh, yeah.
Yeah. But yeah, let's talk about lumps. Lumps and bumps. I think, a lot of people see these, and they can range from a lot of different things. They can be simple lumps like hives, wheals, urticaria. We can actually get into masses. It can be all kind of different kinds of masses. So we're going to hit some high-level stuff on lumps. There's some of these that we're going to really dive into. Because some of them can be like when we get into sarcoids, you could have episode 1, 2, 3, and 4.
Yes.
And still be talking about sarcoids. So let's talk about some lumps. Let's talk about papillomatosis.
Papillomatosis. This is kind of one of my favorites to talk about.
This one?
I like this one just because it's there. Sometimes it looks a little scary, but we don't even have to do anything with it most of the time. So this papillomatosis is just a fancy word for warts.
Yes, warts.
Warts. It's seen in young horses. A lot of times we'll see it in old horses that live near young horses. And it just comes from direct contact with each other, and they can spread through, fomites, which is our fancy word for, objects that touch your horse.
Yeah, because let's kind of start back. We kind of skipped over the part, it's a virus.
It's a virus.
It's a virus. So this is the papilloma virus, the equine papilloma virus. I think it's number 3.
Sure.
I can't remember. But equine papilloma virus is viral-based, spreads. These things look terrible. Of all the lumps, these are probably the ugliest.
Yes, they're very ugly. They look very scary, and sometimes people that have never seen them before will call us in a panic because they seem to just pop up overnight.
They do.
It's like when you look at your horse and they're fine, and the next day their whole muzzle is just...
Right, and they're like, I promise, I just saw them yesterday. They weren't there. I promise, I'm a good horse. And I was like, we know that.
We know. And then, And then, a lot of times they're describing something crazy. They're like, there's just these lumps all over their face, and I think they got into something. I think they got stung is like the thing I hear the most or whatnot. And then we look at it, we're like, oh, they got warts.
Yep.
They got warts.
And they like to show up at the worst possible time because this is more of a young horse condition.
Yes.
So if you happen to have an inspection coming due, they like to show up just before that. If you got fraternity events, if you've got a young horse event, that's typically when they like to show up.
Yes, it is.
Or if they're for sale.
Oh, yeah.
Show up then too. So I don't know why that is, but yeah, it is viral based, so it's spread from horse to horse, nose to nose contact. Sometimes on fomites, but more commonly it's a direct horse to horse contact. And I always tell people, like, these are going to happen.
Yes.
And if you've got young horses,
it's going to happen.
It's going to happen.
The good thing is, though, is that most of the time once they get it, they're not going to get it again.
Nope. The only time I see, like, in older horses, like later in life that are around young horses that have some reason to be immunocompromised. These typically your Cushing's horses, older, just immunocompromised.
Right.
But even then, that's rare.
It's very rare. I think I've only heard it a couple times, but yeah, a lot of times they goes through the young herd and then they're good.
You know, people always ask, what can I do? What can I do? You know, I've read where they used to take these off. You could get what's called an autologous vaccine created. So they would take them, we'd send them out to a lab in Texas. They would essentially freeze dry them, make a killed vaccine, and we'd give it. And the warts would typically resolve in about 3 to 6 months. If you don't do anything, they typically resolve in about 3 to 6 months. So I don't know that anybody's actually doing the vaccine anymore.
No, I don't think they are. Not that I heard of.
It's an older thing they used to do. There's a whole company in Texas that was about wart vaccines.
Wart vaccines.
You know, when people talk about if you go in and start pinching them, and it would release the virus, stimulate the immune system, and get that to help them fall off sooner. Usually, when you go in and do that, it typically works in about 3 to 6 months.
Which is about the same time that it would usually self-resolve. So
what we're getting at is it just needs to, it's self-limiting.
It is self-limiting. That's why it's my favorite one.
Yes.
So.
And it will show up on coronary bands.
It will show up on coronary bands.
Muzzle.
Those ones do look a little scary, though. Like those ones can look a little scary because they can look like other things as well. And so, you know, that's just why if you see this, you're not sure what it is, take a picture of it, send it to your vet, say, hey, what is this? And if we'll come and take a look at it and we'll tell you if you're good or if we need to go start doing something.
And we are going to take a look at it because it can still be other things.
Yes, absolutely.
Like I always say, you know, say a picture's worth 1,000 words. Showing up in person is like worth 1,000,000.
Yes.
So to know that is what we're dealing with. Sometimes I have to deal with these on a cosmetic type situation. If we got inspections, we'll go in and cut them off, freeze them off. You know, I warn people, we get rid of these and there's likely to be some pop right back. I don't know why it feels like it needs to express itself as a wart. Because if you leave those 3, it'll like stay there.
It can't be convenient, no.
But if you take those off, it just pops back up. So I don't know.
Yeah, it's like if you have a big event, you're going to get acne like right before it.
True.
Yeah, like you're going to get a giant pimple right in the middle of your forehead the day before your wedding. It's fine.
That's what happens.
Yeah.
That's what happens. So that's papillomavirus, papillomatosis, warts. Not a whole lot you need to worry about there.
No, it's a pretty, that one's a pretty excellent prognosis for life kind of disease. So we like those ones.
One of the things I do tell people, if you've got a lot of young horses, one of them pops with it, it's kind of like the old chicken pox parties. You're too young for that. But you just sort of send your other horses in and just get this over with.
Exactly. Have it go through the herd now and you're good. Kind of build up their immunity, so to speak. So it's
coming. Now, if your horse is slated for a yearling sale,
just wait.
Let's don't do that. But,
oh man!
All right, so that's definitely a crowd pleaser when we get there.
Yes.
Let's dive into let's go to melanomas first.
Yeah.
Let's go to melanomas
before we get a little.
Yeah, let's go to melanomas. Another very common skin lump.
Very common, and a wide variety of what they can look like too. So in horses, melanomas are unique because in other species, like in humans, we think of melanomas being, UV related. They come after a high UV exposure, which there are very rare variants of that in horses, but most commonly the ones that we're talking about are seen in gray horses. We call it the gray horse curse.
Yeah.
It's almost like every gray horse you have, it's not a question of if they're going to get it, it's a question of when they're going to get it.
Correct.
And I'd say by the time they're usually like late teens, early 20s, they've got some. And some horses just seem to have it way worse than others. It can show up, usually I see it around their tail head, kind of around their genitalia. It can show up on their face, around their eyes. Sometimes it'll show up kind of individual around their body. And they can be just little teeny tiny little dots, or they can be these big clusters of things. And it's one of those things that if you've got a gray horse, it's definitely, something that you need to be prepared for, and something that you need to very closely monitor once you start seeing them pop up.
Because one of the things when we talk about lumps, there's the first classification of lumps are benign or malignant.
Right.
Benign, locally invasive, kind of stay there. Malignant, they spread. And the thing with melanomas is about 90% of them are benign. They do show up in multiple places, but that's not because it's actually malignant and spreading through the body. It just...
Each one is individual.
Right.
It is, yeah, which is...
And you can have malignant and benign melanomas on the same horse.
Yes, you can.
So knowing that most of them are benign, they are locally invasive. But one of the things I like to remind people is too often we just throw melanomas in like, oh, they're just cosmetic. They are still cancer.
Yes.
They are still neoplastic tissue. They are still a tumor. And we have to look at it from where's this located.
Right.
I've seen some of these on the corner of the mouth. I know you've seen them. You go in to do a float.
A dental, yeah.
And the horse is not chewing well, and you open the mouth up, and there's this melanoma. Obviously, that one has to go.
They'll get really large too, like kind of around their anus or around their tail head. They'll get so heavy that they can't even lift their tail.
Yes.
Sometimes I've seen those, and they can actually cause a mechanical obstruction. Where I remember one colic in particular that I worked up during my internship, and it was old gray horse, and go in to do a rectal exam, and I keep feeling this weird structure, and I'm kind of working on an impaction, but it just doesn't feel right. And, unfortunately this horse didn't end up making it, and we necropsied it, and there was a giant melanoma inside of its abdomen.
Yes.
And it was basically getting so large that it was obstructing the gut. And then the outside of this horse, he had some little melanomas here and there. He was an old gray horse. He's going to have some, but it was crazy that he just had this massive one inside of him.
Yes. I've definitely seen those as well. We're going to colic surgery, and we're in there for something else.
Yes.
And then we start finding these melanomas. That was always the thing, is when you put the gray horse on the table, like,
they start showing up.
What are you going to find?
It's almost like if they don't have a bunch on the outside, you're like, where are they?
Yes.
Where are they?
Yes. And before we only had a handful of treatments for these. We could remove them surgically, which unfortunately they're always in the worst spot for surgical removal because they like the tail head, they like the anus, they like the perineal region, they like the sheath, places that aren't the most fun to or most conducive to surgical removal. But we've actually been using a new treatment lately.
Yes.
You kind of brought this into the practice. We actually been using it for a lot of these things. You probably hear a lot about it during this podcast, but let's talk about that.
It's so the drug itself is called Tigolol Tigonate. The brand name is called Stelfonta. And basically the idea is that it causes this major lysis of all of the neoplastic tissue. So it was originally marketed for mast cell tumors in dogs, which is a whole other thing, because mast cell tumors are very aggressive. They're very difficult to deal with, and just the process of getting rid of them is, something that it can cause a lot of inflammation in the body. So you have to, almost combat that with this. And so that was the idea behind this drug. And melanomas can almost do the same thing. Sometimes when you start messing with them, if you're not able to get the whole melanoma in one go, sometimes they'll come back with a vengeance.
Well, I think that's always the difficult thing too when we're dealing with things like melanomas, and later we talk about squamous cells, is where is that margin?
Yes.
So you may take a huge margin to the pathologist, and you may or may not get it all.
Right. And so the idea behind the Stelfonta drug is you inject the drug locally into the lesion, and there's certain calculations we do for the dose, and once you get it in there, it starts to actually slough off that tissue and all of the tissue around it. And they started doing this in some trials at a couple different universities, and so that's how we found out about it, and we brought it into our practice, and we've actually had some really good results with it. We've had, I think, 4 or 5 horses now that we've done it on, and it's done surprisingly well. It takes anywhere from about 2 to 4 weeks for the mass to kind of totally fall off, and it does look kind of ugly when it's happening, but there's the horses are very comfortable. There's really not a lot of burning or itching. They continue to eat, and it's just something that you kind of just have to keep the area clean as all that tissue is kind of falling off, and then once that process stops, it heals completely on its own, and it looks fantastic.
The handful I've used it on, I know you first used it on a melanoma. I've used it on some spindle cell carcinomas, and I was amazed, like when we put this medication in and we put this chemotherapeutic in, because before this we had 5-FU and cisplatin. I've never been like, oh wow, look at that.
Yeah.
I felt like I was injecting saline into them half the time, but with this one, we've put it in, and you're watching it, and nothing's really happening, and then all of a sudden, one day you see like this is starting to die, and the next day this tumor falls off.
You had one fall off in less than a week, I think.
I did. Spindle cell carcinoma on the face that we injected in less than a week. This thing fell off.
It was gone, and I don't even think you could tell that it was there now. I saw that horse like a week ago. I was like, I don't even remember what side of the face it was on.
It's pretty amazing, and that was the same thing with the melanomas you've done.
Yeah.
It is. And I think the key here when we're talking about melanomas, we're talking about Stelfonta, is let's get to it early.
Yes.
Let's don't wait till the entire perianal region is covered. At that point, it's no different than surgery. We can't take that much tissue. We can't lose that much tissue.
Right.
But the smaller ones.
And the lesions we treated them on, they were all individual small lesions. They were all, less than a centimeter diameter. They were singular, so, we weren't taking off big clusters.
Right.
Exactly.
And I've actually used, there is another product called Torigen. And Torigen, we actually send the sample off, and the lab makes a, I don't want to, we often refer to it as a vaccine, but it's actually an immunotherapy where they build similar to a vaccine, but they build something that targets the melanoma itself. And so basically it teaches the body to go attack the melanoma.
Yes.
I've used it in a couple things. I've used it in sarcoids. I did not have great success with that. But shockingly, the melanoma I did, which kind of surprised me, because when we get into sarcoids, they're viral based. Melanomas are not viral based, and you would think if you're building some kind of an immunotherapy, a viral based tumor would be ideal.
Would be better, right?
But I only tried it on I think 3 melanoma. I did it on 3 melanoma cases. 2 of them I got to follow up, and they did well. One of them I lost to follow up. So I don't know how it turned out. But that's another thing. But with the Stelfonta, I'm game. I've been really impressed with seeing your cases that you did with the melanoma.
Yeah, I was pleasantly surprised. I think, when, at least from our perspective, sometimes when we're dealing with these cancers, your expectations are kind of low, I guess, because I think we've all dealt with enough that you're like, this might work, it might not, we might slow it down, but we may not completely get there. And so, we've kind of learned to, tread with caution with these. But yeah, I was very surprised. And I think my clients were as well. They were like, wow, it's like totally gone.
Well, I think for years, when we were dealing with these melanomas, we told people like, hey, there's not really anything we can do. We can try cutting them off, but they're going to keep coming back. Wish we could do more. And now with the Stelfonta, I really think now I'm leaning towards let's get more aggressive sooner. And let's quit just tolerating your horse has melanomas.
Right.
Let's get after these sooner.
Yeah, absolutely.
So, great deal.
Yeah.
Melanomas,
yeah. So kind of summarizing that one, if you own a gray horse, keep track of what they've got. Let us know. Something that I do, whenever I do a physical exam on a gray horse is I, make a little melanoma map and, mark where they are, what do they look like today, and, especially these ones that if we see them and they look like they're getting bigger, let's take some action.
And I think, too, remember that if you do a surgical removal on these, get the histopath.
Yes.
Just because, yes, we can look at it and know it's a melanoma, but get the histopath. I had one that we had to take off of a sheath, and I was like, 90% of these are benign, but I'm going to send it off for histo anyway. I'm big on if I remove something, it gets histo.
Same.
And sure enough, it came back malignant melanoma.
Really?
Came back a malignant melanoma. It was an Andalusian horse. So let's remember, like, if your vet says, hey, I want to send this off for histo, the answer is yes.
The answer is yes.
Just do the histo. Even though it's a melanoma, 90% of the time it is benign. But if you're that 10%, we need to know that.
We need to know that. Absolutely.
So, cool. Melanomas. All right, let's dive into, this is the one, I have a true hatred of this one. I'm getting where I hate it less, and we'll talk about why. But squamous cell carcinoma.
Squamous cell carcinomas.
Yes. It's in the spindle cell carcinoma land.
Yes, it is.
Type. So let's do a little dive into the old squamous cell.
Yes. So squamous cell carcinoma is, I'd say probably, if it's not the top cancer that we see in horses, it's like the second most common.
I'd probably call it number 2.
Number 2.
Well, maybe number 3. I think melanomas and sarcoids.
I think
They're number 1, number 2, because as we're going to remind you, sarcoids are cancer.
Sarcoids are cancer, yes.
We'll get back to that.
But very common cancer. So this type of cancer arises from the epithelial cells. If you kind of go back a couple episodes to our first, that's kind of that top layer of cells. They're all over their body. They cover everything. But these ones very commonly kind of take place at those mucocutaneous junctions, so where you're getting a lot of secretions of things. So your top spots are going to be the eyelids, the lips, genitalia, kind of around their nose and their nostrils. Those are kind of our hot spots for these guys. And they particularly love non-pigmented skin. Yes. So I think your kind of poster child for this is your paint horse with white eyes.
White eyes and white muzzle.
And white muzzle, yes. Those are probably the most common ones that I see when I think about this. And they are heavily related to UV exposure as well. So that is something that, we're definitely going to talk about when we, kind of get a little deeper into, managing this and, kind of trying to prevent this as much as we can.
So, when we talk about that mucocutaneous junction, that's, if you think about the mucosa, is the red stuff you see if you roll the eyelid back, that's mucosa, and then the skin's the outside, and that's where those two come together. The other place I've seen these, upper airways.
Oh, yes.
Upper airways and the pharynx. The sinus loves to get these. And I think the thing I hate the most about squamous cell is they're kind of like icebergs. What we visually see is like 10% of this thing.
Yeah.
It is, by the time we see it, I always say when you see a squamous cell, we're already way behind the 8 ball.
Yeah.
And it's not because people aren't paying attention and we're not looking. It's because they sit there and smolder, and until they show us something on the surface of the skin, we don't know to go look.
Right.
I've had these, I actually had one a few weeks ago. It was a little pony, see this pony all the time, everything was fine. These people pay very close attention, wake up one morning, right side of the face is swollen. Find that, like, I just saw this pony a week before. It was normal. Right side of the face is swollen, has a little bit of a nosebleed. We go get a CT done. And this poor pony, he had a squamous cell that was taking up the entire right frontal and maxillary sinuses. And it had already invaded most of the maxilla and was actually into the soft palate as well, soft and hard palate. So this thing had basically, by the time there was any evidence of it, it had taken over half of its head. And that's not an uncommon story.
No, they're incredibly aggressive tumors. They can be extremely fast growing.
Yes.
And we call that the kind of locally aggressive, that they don't really metastasize in the way that we think about cancers in other species, but they just seem to just take up everything in that area. And unfortunately, like you've said, a lot of times by the time that we catch on to these things, there's not really much we can do at that point. And so, it's one of our things that, hey, if you see something, you need to jump on that fast, because we're already, like you said, probably behind the 8 ball on that.
One of the things I tell people, if you've got these horses with a white around the eyes, white around the muzzles, if you see something that looks like a scratch, get that seen.
Yes.
Because it may not be a scratch. Because oftentimes when we see him, we've got a history of, it just looked like he scraped his nose, or he was kind of rubbing his eye. And then we get there and we see, and a lot of times it's not big. It does look like these little tiny ulcerated, not much bigger than the head of a pin, small ulcerated areas.
Yes.
And it's like, hold up, this is
something.
Yeah, given the non-pigmented skin, and given that this is their squamous cell goes top of our list, because that's how it typically, that's what the early stage looks.
Yes, and I just took one off and I got the histo back and I got the margins on it, but they said the entire margin that I had around it was so severely sun damaged. And when I talked to the owner about it, she's like, well, it did actually, it looked like he just had a really bad sunburn. Until it started showing up and it had that more ulcerated appearance, because she had dealt with this before, but she's like, I thought he just had more of kind of the solar damage. And this is an owner, she's really good about leaving the UV fly masks on and not turning them out in the heat of the day. She's really good about that. But even that, it still popped up, and I think we caught it in time, and it was teeny tiny when we took it, but it's still one of those things that I think we got really lucky with that.
Well, I think one of the things too that when you get these squamous cells, when you talk about you got good margins, that's probably the most important thing that we check, because these squamous cells will have these finger-like margins. They're not well demarcated. And I tell people, when we go in to take a squamous cell off, we're cutting a large area because we want to get it all. We don't know how big it is. It's not like we can see it when we're in there. But we've got to take very, very wide margins. Because if you leave one squamous cell behind, then and I don't know what it is about squamous cell, but I've literally, when I learned this, I did a biopsy on an upper airway, and it was probably the size of a grape. Took a biopsy, and when I got the result back a week later, went back in and looked at it through the scope, and it was the size of a softball. it's like once you touch it, it's a hold my beer, watch this. You
Yeah.
watch me grow, watch this. Mm-hmm. So when we take these off, we're taking a huge margin because we know if we leave one squamous cell behind, it's like angry and
Right.
it will just explode. Mm-hmm. So.
Right. And so a lot of times, when we do take these things off, we'll go ahead and put chemo in there right off
away.
the bat
Yep.
because we're almost anticipating that, even if we feel like we got it, there's probably still some cancer in there. And so
Right.
we're going to, just hit it with everything we've got.
No, it's definitely one that we do not play around with.
No.
And the thing too with these squamous cells is you cannot be too aggressive. Mm-hmm. And I hear a lot of people using cryotherapies, and I don't think that's aggressive enough.
I don't think it is either.
I think you need this is a combination approach. Like, it's very rare I'll just pick like, oh, let's grab just chemo, let's just grab surgery. It's like, no, we're going with both because even though the pathologist says we got good margins, if we left one cell, and again, it's always that cell that sits deeper, and the ones I've seen where I thought I got it all, it comes back, 2 or 3 weeks later, we start to see it again, and then it's like, oh crap, how bad has this gotten? This is one place I have been really, really happy with the Stelfonta as well. Like, I have, like the one I had, it came back on initial biopsy as a spindle cell carcinoma, which that's a kind of like a cousin of squamous cell. Squamous cell is a type of spindle cell.
It is.
So when I used it on this horse, it was amazing how well it worked. And I've even considered it as maybe a primary line of treatment on this one because I didn't do surgical debridement because of the location of it. I just did the Stelfonta, and I have been really impressed with how well it works. One of our other vets did one. It was actually a squamous cell on an eye.
On the eye, yeah.
And now you got to be prepared because this eye is not going to be happy. When we first do this, you're going to have an SPLN. You're going to be on some topical medications. The eye is not going to look happy when we treat it. But within a few weeks, that eye was completely back to normal, no long-term effects. And that horse is actually doing really well.
That's awesome.
So it's I saw some pictures the other day, and it was really pretty incredible how well that eye did. So
I think the big kind of takeaway with squame is, as soon as you see it, we need to get involved. And I think just, kind of setting expectations too. I always tell people that these ones are, going to have a little bit more of a kind of fair to guarded prognosis depending on how quickly we get to it and how aggressive we are with it. I think, following up with these things is probably the most important, is that, hey, we need to continue to come back and look at this thing and treat it and be as aggressive as possible. And even if we do all of that, it may come back, and it may come back with a vengeance.
Well, and the other thing we run into as well is that once you're, like, if you look at these muzzles especially, it's a big muzzle. We got that one squame. We may have resolved that one squamous cell carcinoma, but it doesn't mean another one can't show up.
Exactly.
Because it's had the same UV damage over the years,
over and over and over again.
So this is constant monitoring. We're going to teach you about that, and then we're going to want to see them regularly and really look hard for the next one, because unfortunately, once you've got one, the damage is already there. You're likely to have more.
Yes. So, if you've got a little, non-pigmented, white-skinned horse, avoid UV damage as much as you can. Night turnout, even in the winter, really be careful. You can still get very severe UV damage. Sunscreen is essential for everybody. Always wear your sunscreen. But especially if you've got one of these, light-skinned horses, make sure you're using sunscreen. UV fly masks. There's a lot of good models out there, and don't skimp on it. Get one of the nice ones.
Well, and one thing that I really love, the UV fly mask with the nose protectors that go all the way over the nose. And I prefer those over sunscreen because no different than sunscreen in the pool, you've got to constantly reapply. And your horse is going to bury his nose down in the water trough. That sunscreen's washing off.
They're going to sweat. Yep.
And just get the UV mask with the nose protector, cover this area. It's almost like if you have a choice between wearing sunscreen or a sun shirt, that sun shirt is way more protective than a sunscreen. I never thought I'd be a sun shirt wearer, but
you're as bad as my husband. He's like, he refuses to put on sunscreen, but he'll wear the whole thing. And I'm like, will you please just put on some sunscreen?
I hate sunscreen. I don't like the way it feels. But I put on my sun shirt and go fish all day in the sun. Do it all day. Love my sun shirt.
Oh my God.
So protect it.
Yes, protect it. Yes.
So
it's better than nothing. Yep. So
squamous cell takeaways. Do not wait. If you think you may have one, get it checked out. Don't be afraid to biopsy. And then if you do, this is not the time to take a conservative route. My rule on squamous cell is we want to kill mosquitoes with sledgehammers, because squamous cell cannot be dead enough, in my opinion. It's awful.
Cannot be dead enough.
It's awful. I hate squamous cell.
Yeah,
hate it.
It's not a fun one. Speaking of not a fun one,
sarcoids.
Sarcoids.
All right, I'm gonna just stop here. We're gonna do a high level overview. We'll come back and do a deep dive.
Yeah.
And I swear this is probably the one. When we do that sarcoid episode, I guarantee you we're gonna have comments, because this is
like universal. It's like it's every horse, it's every breed, it's every environment. They'll show up wherever they want. They can look like almost anything, and they're a pain in the butt.
Yep, and it's a viral based tumor. Bovine. It's the bovine
papilloma virus. Yes.
So if your horse has a sarcoid, it has somehow found the bovine papilloma virus. It knows what cows are. So spread by flies. So jumps over to horses, the virus infects, and these masses start popping up.
Yes, and when I say they can look like anything, they can look like anything, from just these kind of little spots where there's like a lack of hair and like a little plaque thing, to these like real nasty ulcerated big softball masses, and they can look anything like that in that spectrum. They all have different names. We can kind of go through that in our later episode, like kind of deep diving into each one. And some of them are a little easier for us to deal with than others, and even then, when I say easy to deal with, there's an asterisk with that. So
I think the easy to deal with part is you have to remember this virus is in your horse. It's a papilloma virus. It's there forever. We may resolve the one, but they may show up somewhere else. We cannot stop this from happening. It's not like we took this mass off, it's not coming back. This is, I have this virus. Today seems like a good day to grow a sarcoid on my neck.
And they can come from wounds too. I've seen like these horses that get sometimes like it's something as simple as like a bite wound from another horse. All of a sudden it's like, well, great, now there's a sarcoid there. Should have just healed up within a couple days, and like now we've got a whole nother problem.
Well, and that's where I think these get missed a lot, is that horses will have a mild abrasion, it heals back, it doesn't ever hair back in, and people think it's just damage to the skin from the bite, and then we're out there for vaccines or some other reason, we look at it like, oh no, that's a sarcoid.
That's a sarcoid, yeah.
And the one thing I want to say is oftentimes these get ignored. They're like, and I hate this word, it's just a sarcoid. It is cancer. It is not just a sarcoid. It's not just a sarcoid. We need to do something. Like these, because I remember, I can't tell you how many of these I've seen where it's like, all right, we've got this small sarcoid, let's get this off now. And people are like, well, I'm going to hold off, and I get it, it's show season, not a great time to be down. Well, that's fine, but we need to keep monitoring this, because I've had them push it off, and then it comes in, it's like, now I've got a Frisbee size mass that has to come off.
And,
like, before it was the size of a quarter, now I got a Frisbee. They can grow, and that's the thing, it's like, that's why I don't like it's just a sarcoid, because then people tend to ignore it. Like, no, it's not just a sarcoid.
And these are these ones too that, like, if you don't get the whole thing in one go, if you're trying to excise it, it comes back so awful. Like, I've seen these things just start from like a little tiny thing to like, it's like their whole chest.
Right.
In like the matter of a couple of weeks. And I'm like, well, crap, now what do we do? So.
Well, a lot of times we get these ones that are on the ventral abdomen, on the belly.
Yeah.
And one of the things people say is like, well, can't we just sedate him here, do a local block, and take it off? I'm like, I would rather not, because, again, what you see on the surface may not be all of it.
Correct.
If I can actually, and you're down there like underneath the horse trying to look up, you can't visualize this thing. And
No.
it'll look like it's hanging from a stalk. But I put enough of those on the table that when I open them up, you like all of a sudden see the fingers. Like it's more than what we see.
Yes.
And so if your vet's like, hey, I really would rather lay your horse down because that way I can make sure I get it all. Like, again, say yes.
Yes. And this is another one of these things. It's not just to hack it off and be done with it. Like, this is something that if we are going to, take it off or treat it, we need to be following up with it on the regular, because most of the time I'd say these are, we're going to be hitting them with that kind of multimodal treatment. We're going to be, excising and then doing some sort of, chemotherapy or something to try to get with these, because we know that these are very, very violent tumors.
Yes. And there's other options. Like I'm a big fan of cutting them off.
Yeah.
So one of the things I like to use sometimes is Xterra paste. It's a caustic paste that goes on. You put directly onto the sarcoid, and because it's caustic, you can actually start, for lack of a better word, it destroys that tissue. But you have to pick and choose where you use this, because it's not like, oh, I'm just going to be caustic to the sarcoid. It kind of is caustic to everything. And so ears, bad place. Around the face and eyes, bad place. I guess where I use it a lot is like some of these on the ventral abdomen. I'll try it on those. Because again, gravity says it just falls off. It's not going to run down the side of the horse and cause issues. So, but I will use Xterra sometimes. But again, when I can, I want to cut these off.
Yes.
And then there are always those lucky ones, and we're going to talk about this more when we get into sarcoids, that will spontaneously resolve.
They just go away, yeah.
And we don't know why. It just went away. And that's usually the ones that somebody's put some Crest toothpaste on, or...
I forgot about the Crest toothpaste. Yes.
Crest toothpaste.
Oh, man.
And usually people are like, I put Crest toothpaste on it and it went away. No, it spontaneously resolved. You got lucky.
I forgot about the toothpaste.
Yeah,
Oh,
Crest
yes.
toothpaste. And we'll get into this later, but I swear there is more witchcraft that comes out in sarcoid treatment than
There really is.
anything out there. And it's just being straight and honest with you. Some of these things, if it works, it's because that thing was going to resolve no matter what.
I'm pretty sure I saw an ad on TikTok for like some sort of like feed through supplement, and it was just a bunch of herbs, and I'm like, okay, let me know how that goes for you.
Yeah. So,
If it works, then like I'll hear your pitch, but I mean, I was like, okay, maybe they know something I don't, but
yeah, I'm kind of right there with you. Let's skip the witchcraft and let's get after this, because I've seen these involve the entire neck. Like I had a horse that literally it went from the shoulder dang near to the pole.
ugh,
Like the whole side of its neck, and it started with something small, and nobody did anything about it, and then it just all of a sudden it's like, because again it kind of creeps underneath the skin, and it can literally, what you see on the surface is like an iceberg. It's the rest of it. And of course, by the time everybody's like, hey, let's do something about this, it's like, do what? Like I can't, there's nothing I can do, because I can't take this whole thing
can't take his whole neck.
Like it just, I'm out of options. Like now we're living with it.
Yeah.
So, I think a good rule of thumb: early intervention.
Yes.
Aggressive intervention. This is not time to safety up. This is early and aggressive. I think this goes for squamous cells and it goes for sarcoids and a lot of these lumps and bumps. Early, aggressive intervention.
Yes.
They are cancer. Early aggressive intervention.
Except for the papillomas.
Except for the papillomas.
Those are just warts.
Yeah, papillomas, they'll go away. That's what I was saying, the cancers.
The cancers, yes.
Papilloma, not a cancer. So these are true cancers. So early aggressive intervention. So what's your, we're wrapping things up. Like we've gone through, like I said, sarcoids. We're not going to take a deep dive into that. Maybe that'll be one of our next podcasts. Let's go ahead and do the deep dive into sarcoid land.
Yes.
But we just wanted to hit a small highlight of all these, and we'll kind of break a lot of these down and get a little deeper into them. But, maybe we'll do sarcoids next. But so key takeaways, like we would call this the basics of lumpology, the basics of lumps and bumps. What are your key takeaways?
I mean, I think you just said it best, early aggressive intervention. If you start to see these things, snag some pictures, get us involved. We'll come take a look at it. And, I love pictures. I love watching these things. Anytime I do any sort of thing related to a mass, you'll see me on my phone taking pictures of it because I want to see how we're responding to the treatment. And I want to be aggressive with it. We need to follow up with these. And, and if we're in the middle of treatment and things aren't going well, we need to be able to address that.
There's a lot of things you do really well, and this is one of those. You're really good about recording the pictures. I see you with our micrometer out there measuring these and getting pictures. That is one of the things. There's a lot of things you do really, really well, but that's one of them on lumps and bumps. Like I tell people you're kind of the go-to there because
scroll through my phone. All it is just lumps. There's just lumps and yep.
Yeah, I would say get a correct diagnosis. Don't be afraid of histopathology. Get a correct diagnosis. You can't. I think one of the greatest sayings I ever heard is surgery is trauma, medicine is poison, alternatives are witchcraft, absent a diagnosis.
Can we get that on a bumper sticker?
I think we should. I can't remember. I saw it. One of my friends was. He's a equine. He's an equine veterinarian that specializes in dentistry. And I was at a CE. He was teaching. Shout out to Nick Moore for this. He was teaching the CE I was at, and he had that on the slide. Surgery is trauma, medicine is poison, and alternatives witchcraft, absent a diagnosis. And I remember. I never forgot that. And I would say that's really important here is this is not time to shotgun treatment.
No.
Because each one of these are different. Not time to shotgun. We need to go get a diagnosis. So visual appearance, and then when in doubt, histopathology, knowing what you're targeting. I think that is mission critical here. Because again, we need to know what we're dealing with. And a lot of these things, unfortunately, sarcoids, squamous cell, spindle cell carcinomas, these three can actually all look really similar.
They can. Yes, they can.
Very similar. Similar age when they show up. They can show up at any age.
Any age, but.
So that's why they're all similar age, because they can show up at any age. These are all important to know what we're dealing with.
Yes.
Same thing with some of these melanomas. Again, malignant, benign. Let's know. So I agree 100% what you're saying.
Yeah.
Kill a mosquito with sledgehammers. Get an accurate diagnosis. This is not a wait and see time. Not a wait and see.
Nope.
So. All right.
Oh, cool topic.
Yes, loved it.
Topic.
Love lumpology, love lumps and bumps. Let's do some deeper dives into these lumps and bumps because we haven't even scratched the surface. So
no.
Really cool. Dr. Brown, thanks for being here today.
Thanks for having me.
Thanks for this awesome team we got. April getting everything recorded. Casey, thank you for editing. I had no idea how much editing we do. But it's a lot.
It's a lot, yeah.
So, and thank you for all our listeners out there. We got listeners, we found out, in I think, how many of the different states? All 40? Have we made all 50 states yet?
I don't think we're at all 50.
No, it's in the 40s, all 40-something states. Again, 50-something countries.
Yeah, 59 countries.
Yes. It's really cool. So
that's awesome. That's so cool.
We're just happy everybody's out there listening. We hope we can keep bringing y'all topics you want to hear about. Let us know. Send us a message, emails, DMs.
Tweets.
Oh, I don't think we got tweets.
It's X, I think. I don't think it's Twitter anymore.
You can. It's Facebook. That's a DM, isn't it? No, it's a PM.
A PM? What's a PM?
I think it's a private message.
Oh.
A private message. I don't know. I'm learning stuff.
So with it. You're so with the times, Dan.
Yeah, just reach out to us somehow. Pick up a phone, call us. I don't know. But yeah, let us know what you want to hear about. We'll keep cranking topics. I know we're getting a lot of requests for them, and we're getting to them, but we still have real jobs. We don't get to the podcast all day, every day. So
not yet.
Not yet.
One day.
One day we'll be podcasting.
One day when the AI replaces us and all we can do is talk. So.
We'll come in with our canes
Yep.
and sit down and we'll podcast all day. So again, thank y'all for tuning in. Thank y'all for listening. Y'all have a great, great week, and we'll see y'all next week.
Bye,
Thanks.
y'all.
Bye.